Go ahead and get started. For those of you that don't know me, I'm Ryan Shelton. I'm the EMS manager for UC Health. We're joined tonight by Carrie Jefferson. She is the stroke program manager. And one of the things that she has specialized in is uh, people's brains. And the nice thing about her that I would say is a little bit unusual. So it doesn't matter what stroke is coming through the hospital, whether it came from the floor, whether it came pre-hospital, about 9 times out of 10, you will see her right at the bedside. Kind of as we raise through the ranks, sometimes it's very difficult or we get pulled away. And that component of that patient care and being at bedside tends to be one of those things that gets torn away from us first. That is not the case with Carrie, and it speaks to her passion and everything that she brings to the table to take care of our stroke patients. So I would say that UC Health has, as a comprehensive stroke center, can muster up against the very best in the country, and it's because of people like Carrie here that make that happen and then continually push forward. One of the things that she tirelessly does is push the stroke team forward to doesn't matter what it is, but in the pursuit of better patient care and better patient care, and even the smallest increments of making improvements, she tirelessly seeks after those. So she's always pushing me forward and forward and forward and faster and faster and faster. And we appreciate her very much for the hard work that she puts in. She's very dedicated. So with that, here's Carrie.
Well, thanks, Ryan. That was very nice. Yeah, I think I probably wouldn't be in this job if I couldn't still see patients. That's the reason I got into it, and I still like to be in the mix of things. It makes the job enjoyable, and it reminds me of why I do what I do. So, and I also love teaching the people that are also going to touch patients. So I appreciate you having me here. Put questions in the chat. Ryan, if you don't mind looking at the chat and letting me know if there are questions. I'm happy to answer questions as we go through or at the end, whatever you guys want. All right, so I'm going to talk to you guys about stroke. We're going to go through stroke timelines and treatments of stroke. So besides wanting to take care of patients, let's talk about why recognizing a stroke is important. So about 2 million neurons will die per minute in the human brain for an untreated large vessel occlusion. And we'll go through large vessel occlusion a little bit later in the slides. So when we delay treatment by 30 minutes, that can decrease a patient's functional outcome by 10% at 90 days. So that means a patient could be walking independently versus in a wheelchair. And that brain ages 3.6 years each hour without treatment. So the earlier we treat somebody, the better their chance of recovery is, regardless of what type of treatment we're going to provide that patient. So we want to make sure that people are recognizing a stroke, whether that's the community, whether that's EMS when people call 911, so that we can get people treated as quickly as possible. We want to make sure that we're not killing off those neurons, that we are providing them with the best chance of minimal or no disability when they leave the hospital. So EMS is a huge part of what we do. And when EMS calls a stroke alert before that patient arrives to the hospital, there's much faster hospital times. So one, you're calling ahead. So we're sitting there, we're waiting at the door. We've dropped everything else that we were doing and we show up for that patient. You guys place IVs, draw labs, and then we can go straight to CT with that patient because that's where everything starts for us. We need to get that head CT before we start doing anything else to treat this patient. And our door to CT time is about 12 minutes faster when EMS calls ahead. So 9 minutes versus 21 minutes. And so we're saving neurons there, right? That's a big, huge savings when you guys call ahead. So let's go through the different types of strokes that we have. So these are CT slices of the brain. and they're called coronal slices, and they just kind of go through like this. This is just one slice of the brain. So we have ischemic strokes. So that's going to be about 85% of all strokes that we see. So the most common type of strokes. Anything on CT that is white, that shows up white, is going to be bone, blood, or bling. So any sort of type of metal in the brain. And this hypodensity, we call this a hypodensity. So this dark area here, hopefully you guys can see my pointer. But this triangle looking area here is an ischemic stroke. So an ischemic stroke is going to show up on CT about 6 hours after the stroke has happened. So when we actually want to give thrombolytics to a patient, we want to see a normal head CT. This CT is too late, and that stroke is already completed, and there's nothing we can do for that patient. Other types of strokes, we have the intracerebral hemorrhage. So that is bleeding into the brain tissue itself. So you can see this white area here, that is an intracerebral hemorrhage. And then we have a subarachnoid hemorrhage, and a subarachnoid hemorrhage is bleeding around the brain. So you can see this like whitish, grayish area, and that's the blood that has spilled around that brain tissue. So like I mentioned, ischemic stroke, that's 85% of all strokes. And that's when there's a diminished blood supply to an area in the brain. So a blood clot has gotten into that vessel in the brain, and that area is no longer getting blood flow. So it's starting to die. It's not getting oxygen. It's not getting nutrients. Most often that's due to a thromboembolism. So blood clot forms somewhere else in the body, breaks off from that area, and then travels up into the brain. Sources of clots that we can see, or reasons why this happens, they can come from the heart. So atrial fibrillation, patients sometimes don't know they have atrial fibrillation. They're going in and out. They don't have any symptoms. And so blood clots can form in the heart from that. They can form, we can have blood clots that form in these large arteries that go up our neck, these carotid arteries. So a lot of times plaque develops there, and that plaque can rupture and either develop a blood clot there from the blood flow not being smooth through there, or a piece of that plaque can break off itself and go into the brain and plug one of those arteries. We also have small arteries throughout the brain, and those can build up something called lipoproteins from longstanding high cholesterol and diabetes and smoking. And that basically just clots off over time until it's no longer getting more blood flow. And that can cause a stroke in those areas. And then there's various different types of hypercoagulable states out there. So this can happen in younger patients. When we see younger patients that have strokes, we always try to figure out if they have a hypercoagulable disorder that we're not seeing. So, factor V Leiden or prothrombin gene mutation. Other things that can cause hypercoagulable state is cancer or patients that are on hormone replacement therapy. Hemorrhagic strokes, so that's about 15% of all strokes. So that's the remaining ones. And remember, this is not due to trauma. So it's an intracerebral hemorrhage and a subarachnoid hemorrhage not due to trauma that is defined as a stroke. And a hemorrhagic stroke is when a blood vessel has ruptured within that skull. And the intracerebral hemorrhage is into the brain tissue. Most common causes of an intracerebral hemorrhage is high blood pressure. Patients that have long-standing high blood pressure, we have our arteries, and that high pressure is kind of just keeps going and going against those arteries. And then eventually those arteries start to weaken and the wall gets thinner and thinner. And then eventually it pops a hole and blood spills into that brain tissue. Other common causes are vessel malformations. One of those is an arterial venous malformation. You can kind of see this schematic here at the bottom. What that is when the arteries and the veins come together without the capillaries in between. And so we don't have that slowdown between that high pressure to the low pressure. And so that can cause that to rupture and spill into the brain. Tumors sometimes hemorrhage, and then patients that have bleeding abnormalities kind of on the reverse side, right? So somebody that doesn't have enough clotting factors, like someone that has a hemophilia or von Willebrand's disease, or patients that, are on anticoagulants that they want their blood to be thinner, but sometimes, especially in older patients, they can have spontaneous hemorrhages from that. And then there's the subarachnoid hemorrhage. So this is bleeding, like I said, around the brain into the subarachnoid space. Most common cause of this is going to be an aneurysm rupture. Most common cause of aneurysms are, again, that high blood pressure. So we have that vessel, and this is kind of a good schematic down here. We have that, artery, and from that longstanding high blood pressure, that vessel just gets weaker and weaker and weaker, and it causes like a little balloon on the side. And then eventually that balloon gets too thin, and again, it ruptures, pops a hole in that balloon, and blood spills into that subarachnoid space. And we also have those vessel malformations that can happen in that subarachnoid space in the brain. I'm going to mention TIAs, or transient ischemic attacks, similar to an ischemic stroke. So it's that brief interruption of blood supply to the brain. So a blood clot goes into the brain. It's going to cause the same symptoms that an ischemic stroke will cause, but our body naturally breaks that up. It breaks that clot up, and that symptoms will resolve as that brain gets blood back to that area. For TIAs, there's no infarct, so there's no dead tissue. It hasn't sat there long enough to cause any of that tissue to die when we do an MRI. So it's similar to the angina of the brain. And the one thing about this is we do want patients to come in if they've had a TIA. So if you can encourage patients to come on in, let's get you evaluated, because a lot of these patients will go on to actually have a stroke within the next few months, because we need to figure out why that happened to them. Do they have that AFib that they don't know they have? Or is there other risk factors for stroke that we need to take care of better, so that they don't actually go on to have a stroke in the future? Okay, so looking at the clinical symptoms of a patient really help us figure out where the stroke is happening in the brain, or do we even think this patient is having a stroke? So that's the first thing we want to think about when a patient is coming to the hospital. Do we actually think that this is a stroke? So the cerebrum here in this big dark area out here is the largest part of your brain. And it essentially has everything that makes you who you are. So your intelligence, memory, personality, speech, your ability to feel, your ability to move. And then that has two halves. So there's a right and left half, and they're connected in the middle by the corpus callosum, so that the two halves can communicate. Because as you guys know, the right side of your brain works the left side of your body, and then the opposite. So if we break that cerebrum up, we have your cerebral cortex. So this is the gray matter out here. And that is the part that has all your high functioning processes that I mentioned. And then we have your cerebral subcortex. And this subcortex is really, really complex, but it basically keeps the homeostasis of the brain. So it controls things like temperature, hormone release, eating, drinking, sleep, wake, and emotion. And then back here we have the cerebellum. And the cerebellum is responsible for balance, movement, and coordination. And then we have the ever important brainstem. Okay, so that connects your cerebrum to your spinal cord. And that takes in and sends out messages and really coordinates those brain messages, sending them to the body. And then it controls many of our automatic functions that we don't even need to think about. So breathing, heart rate, blood pressure, swallowing, digestion, and blinking. So I mentioned that cerebral cortex, so that big outer layer of the brain that has all those high functioning things that we do. That's broken into 4 different lobes. And you may remember these, but we have the frontal lobe here in red, parietal lobe in yellow, occipital lobe in the back in blue, and then your temporal lobe in purple here. And we'll go through really what those lobes are doing and how we can localize a stroke to those areas in the brain. Just outside of the brain, we have the meninges. You can see those kind of depicted here. And then we have the skull. And the skull is a very rigid box, right? So it's trying to keep the brain safe. It contains blood, cerebrospinal fluid, and brain tissue. So any changes in one of these can cause huge disruptions in the brain because there's only so much room inside that closed box. And these meninges are really also what helps pad the brain. So that's an easy mnemonic to help remember the meninges of the brain. So going over here, we have the first layer is the P, that's the pia mater. And then we have the arachnoid space right through here. And that contains all of our big blood vessels and where the cerebrospinal fluid is running through. And then we have our dura, which is the final, like really tough layer outside of that space there. So for our brain to work, like I mentioned, we need to get blood supply, right? So we can get oxygen and nutrients. And here are those main arteries that supply blood to the brain. So they're broken up into anterior and posterior circulation. So we're feeding the front of the brain and the back of the brain, right? So the front of the brain is fed, by this internal carotid artery here. So coming off the aorta, we have the common carotid, and then the carotid breaks into the external and the internal carotid. The internal carotid is what goes into the brain and helps supply blood to the front of the brain. And then these bluer areas, we have the vertebral artery coming off the subclavian artery. So we have the vertebral artery kind of going up the back of the neck into the brain. And then they connect to form the basilar artery, which goes up our brainstem again. And then that forms the circle of Willis. And the circle of Willis is a really cool feature the brain has. It isn't perfect in everybody like this, but when it's perfect, this is what it looks like. And it's in a circle. So if one area of the brain is blocked, so if we have a clot that's sitting in this artery over here, the brain then tries to push blood to that area of the brain so that it can minimize that damage. It can minimize that damage to that tissue for a certain amount of time, right? We need to get that clot out. We need to get that artery open, but the brain does try to push blood over to that area. So a lot of times that's why you see patients that are having a stroke have really high blood pressure, because they're really trying to push blood to that area of the brain. Again, this circle of Willis, we break it up into anterior and posterior. So this black line kind of depicts that, but we have that internal carotid artery that I mentioned coming up into the brain. That middle cerebral artery comes off of that, and it feeds a large part of the brain, frontal parietal lobe. The middle cerebral artery is connected to the front of the brain. So these anterior cerebral arteries right here, these little antennas feed the front of the brain. They're connected by the anterior communicating artery here. And then the front and the back is connected by the posterior communicating artery here on both sides. And then for the back of the brain, remember I mentioned those vertebral arteries that are coming up the neck and into the brain, and then form the basilar artery, which goes up our brain stem. And then at the top of the brainstem, it breaks up into the posterior cerebral artery. So those are like the major arteries that we're thinking of when we're talking about large vessel occlusions. These are those large vessel arteries in our brain. And then that's what we're talking about when we mention that. So again, the circle of Willis is what's feeding those major areas in our brain. So that in that cerebral cortex, those frontal lobes, parietal lobes, occipital lobes, and temporal lobes. Okay, so they're feeding all those areas of the brain. And so we can try and figure out where that stroke is based on what those patients look like. So for instance, if a patient is having expressive aphasia, so they're not able to get their words out, we can think that the patient is probably having a stroke in this Broca's area. So that's what that is responsible for. It's responsible for us being able to express our words. Or if a patient is not able to understand our commands or understand us, we call that receptive aphasia. So they're not able to receive our information. And so we think that that then could be a stroke happening in the Wernicke's area when we see that, because the Wernicke's area in the brain is responsible for that language. Oh, I want to go back 1 second. And then if a patient is having any motor or sensory loss, we think that the stroke is probably happening in one of these areas here. So we have a motor strip and a sensory strip right behind it. And these are responsible for most of our larger movements and sensation. So this next slide will kind of show those areas. If we were to take them out of the brain and kind of lay them flat. And this homunculus man helps us remember what areas of the brain are responsible for what movements in our body. So going back to those circle of Willis and those major arteries, the anterior cerebral artery feeds this part of the motor and sensory strip. And so when we see a patient with more leg weakness than arm or face, we're thinking, oh, that could probably be an anterior cerebral artery stroke. And then this area here, this big green area, is the middle cerebral artery. And so when we see a patient that's having more face and arm weakness than leg weakness, a lot of times we're thinking, oh, that's probably a middle cerebral artery stroke. And then down here, not depicted by the homunculus man, but down here is that posterior cerebral artery that I mentioned. And the posterior cerebral artery is feeding the back of our brain, so that occipital lobe. And this is the area where we interpret what we are seeing with our eyes. This part of the brain that interprets our vision. And so when we have any visual loss, we can think that it's probably coming, there might be a stroke in that posterior cerebral artery and coming from that occipital lobe. So those...
Quick question before you go on there.
Oh, sure.
Back on that 2 slides ago, it showed audio 1, 2, and 3. Did the 1, 2, and 3 mean anything specific, or was it due to like left eye blindness, right eye blindness, or anything? It's in the purple area.
Oh, in the purple. Yeah, this is the visual fields. To be honest, I don't know exactly what they're depicting here necessarily. So our visual fields, so we get the information from our eyes, and then the oculomotor tract goes from our eyes all the way kind of through our brain and then gives that information to the occipital lobe to interpret. So a lot of times when we're having different types of visual loss, it really depends on where in that occipital oculomotor tract, optic tract that the stroke is happening throughout our brain. So that's really what depends on what kind of visual loss that patient is going to have. And I'll show you the different visual losses in a slide later, but so I'm not actually sure. I use this slide more for the Broca's and the Wernicke's, so I'm sorry, I can't answer that question.
No, that's fine. I like the colors in it with showing different stuff. It's great.
Yeah.
Thank you.
Yeah. Okay, so those major arteries in the brain, like I mentioned, those large vessel occlusions are going to give you certain symptoms, right? Because we're localizing that to an area of the brain. It's affecting a part of that homunculus man. And so what those patients look like, we can really say what part of the brain is having a stroke. So we're going to go over some of those major stroke syndromes that you can see when a patient's having a large vessel occlusion. So when a patient's having a stroke on the left side of their brain, so that left middle cerebral artery, remember the left side of the brain works the right side of the body. So we're going to see right-sided weakness, sensory loss. We can see a right-sided visual field cut if it's big enough. And then patients tend to look towards their stroke. So that's the only thing that's not going to be kind of the opposite. So a patient will basically kind of say, hey, I'm having a stroke on the left side of my brain, because they're going to be looking to the left, and then they'll have right-sided weakness. And then the left side of the brain is dominant, or it's kind of the language center for about 97% of the population. And so most often with a left-sided stroke, you're going to see those aphasias that I mentioned. So you can see expressive aphasia, receptive aphasia, or you're going to see a mix of both. And I know that aphasia and dysarthria are kind of confusing and kind of difficult to suss out sometimes. And so if this works, I'm going to show you some differences of aphasia and dysarthria and some examples of that. So remember that aphasia is using wrong or inappropriate words, or they can't follow tasks, whereas dysarthria is more of a motor weakness. So they're having that really slurred speech that they're able to, make sense to you. Let me know if you guys can hear this. I'm sorry for the commercials.
What makes you feel whole.
So how are you doing today, Kent?
Okay.
Okay. Are you having pain anywhere?
No.
No? You feel pretty good in general?
Yes.
You can understand what I'm saying to you, right?
Yes.
Okay. Can you close your eyes for me? Perfect. Now tell me your name.
George. Cause I've had. No.
So he's having expressive aphasia, right? So he's able to follow commands and say some words, but he just, is not fluent in his language, and he can't get some of those words out. And then this guy. Again, sorry for the commercials. Oh, there's no commercial on this one. That's good.
Hi Byron, how are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get
will
to
store it
Juneau.
right here and they'll save their hands right there. For them.
So that's more of a fluent aphasia. So he's just speaking nonsense, right? Like you have no idea what he's trying to say, but he's able to get all his words out. So he's having more of a fluent aphasia. And then this is not a stroke, but it was the best I could find for dysarthria.
So the first thing you noticed was the speech,
Yes.
and has it gotten worse?
When I get stressed, it gets worse.
Right.
But other than that, not so much.
When people are still able to understand everything you're saying.
Pretty much.
Yeah, I can understand you real clear.
Yes.
Okay. And on the telephone, are they able to understand?
Pretty much.
Yeah.
Yeah.
Can you repeat this sound? Pa pa pa.
Pop, pop.
Ma ma ma.
Ma.
Now the tongue sound la la la.
La.
Speech, and I had a good home therapist at daycare, had me ENT and beer and swallow.
So you can kind of see the difference, like the motor is in the speech is more causing those patients to make that more slurred, but they can understand you and, follow your commands. That's just the speech is very, very slurred. Okay, so when we're having a stroke in the right side of the brain, so that right MCA area, we're going to see left-sided symptoms. So we're going to see left-sided weakness, sensory loss, possibly a left-sided visual field cut. Again, we're going to look towards our stroke. So we're going to look towards the right with left-sided weakness. And then what happens with right MCA strokes, or what can happen, is something called neglect. And neglect is when the patient is ignoring that left side of the body. And they might ignore that left side of the world if it's severe enough. So neglect can range from a little bit to a lot, where they can even, you put your arm in front of them and you say, whose arm is this? And they're like, oh, that's your arm. And they don't even recognize their own arm. So they're not really even recognizing that left side of their body or the left side of the world. EMS picked up one of our patients. Somebody called 911 because he kind of was swerving, ended up thankfully not getting in a car accident, but ended up pulling over into a parking lot. And when EMS got there, he was actually trying to get out of the right side of his car because he didn't know the left side of the world existed. And so he was constantly trying to get out on the passenger side. Is that what I said? So get out on the passenger side. He didn't know the driver's door existed. So those are some severe examples of neglect. This is just a CT scan example of a right middle cerebral artery stroke. Again, you can see these hypodensities or these dark areas in the brain, which means that that brain tissue has already died. All right, a brainstem stroke, basically kind of all bets are off. Brainstem strokes are where almost all of the cranial nerves originate. And so lots of different symptoms can happen when we're having a brainstem stroke. Brainstem strokes are the only strokes where we can see decreased level of consciousness, besides hemorrhagic strokes. But when we're talking about ischemic strokes, they're the only strokes that can have that decreased level of consciousness. But what you want to think about with a brainstem stroke is how it was described. Did it happen all of a sudden? So if we're thinking of a stroke, if somebody says, well, all of a sudden he, became altered and we couldn't wake him up, then start thinking about stroke and putting that on your differential. Other things that can happen with a brainstem stroke, like I said, they're all over the place, but you can have weakness on one side of the body. All four limbs can be weak. Same thing with sensation. You can have cross signs. You can have numbness on one side of the body, weakness on the other. You can have some ataxia or discoordination, vertigo, nausea, vomiting. You can have some double vision, like this guy who I can't even really look at. Disconjugate gazes, nystagmus, where you have beating when the patients look to one side, their eyes beat, they keep beating. Dysarthria, impaired swallowing, I said the decreased level of consciousness, and then abnormal respirations. So just think about all of a sudden what kind of symptoms happen to a patient when you're talking to patients. Here's an example of a stroke, hemorrhagic stroke in a brainstem. So this is in the pons, this white area here. And then we have that cerebellum. So remember, the cerebellum is balance and coordination. So when a stroke happens there, obviously that's what's going to be affected, right? So a stroke in the cerebellum can cause ataxia or discoordination. So doing finger to nose, that patient is not hitting their mark, or the patient, when they walk to your stretcher, they're walking almost like they're drunk, or they have like a really wide based gait, or even when they're sitting up, they can't hold their trunk up. So that's called truncal ataxia, where they're not able to hold up their trunk while they're sitting up. Other things we can see is dizziness, vertigo, nausea, vomiting with a cerebellar stroke. And then these are just some examples. There's a few different arteries that feed the cerebellum and can cause different strokes in different areas of that brain. The anterior cerebral artery, so it's least commonly affected by stroke because there's a lot of twists and turns that clot has to do to get up to the front of the brain. The most common stroke that we see is the middle cerebral artery because it's just a straight shot from that carotid artery into that middle cerebral artery. So since we don't see them very often, and They cause a little bit different of symptoms. They can easily go misdiagnosed and not caught until later. But some classic signs of an anterior cerebral artery stroke, remember it's feeding that front of the brain where that leg was hanging over. So we're going to see leg weakness, sensory loss. And then since it's feeding the front of the brain, we can see things like behavior abnormalities or possibly some incontinence. This is an example of an anterior cerebral artery stroke, CT here, and this is an MRI. Ischemic strokes show up white on an MRI. So you can see that we kind of call it a mohawk. And here's those different effects that a stroke from the posterior cerebral artery can have. So the different types of visual loss. So that posterior cerebral artery, remember, is feeding the occipital lobe. And depending on where that stroke is, patients can complain of different types of visual loss. So we can have half of the vision affected, or it could just be a quarter. But with stroke, it's going to be the same area in both sides of the eyes, if that makes sense. So if a patient is complaining of visual loss, they'll have visual loss on the right eye in the right half of the eye, plus the left half or the right half of the left eye. So it'll be the same area in both eyes. Okay. If a posterior cerebral artery stroke is big enough, it might cause some weakness or sensory loss, or if there's a left PCA, if it's big enough, it might cause some aphasia, or a right PCA if it's big enough, might cause some neglect. So it's pushing into that parietal lobe. And then this is just an example of that posterior cerebral artery stroke, what that looks like on CT. I mentioned how complex that subcortical or the deep tissue in the brain is. So I'm not going to get too much into that subcortical area, but I wanted to point out that all of those neurons that we were talking about that are fed by those big arteries in the brain now come together into that deeper area of the brain. So they're all kind of coming together into one area. So a small stroke can cause big symptoms when it happens in the subcortical area. And then these are some examples of, strokes in that area. They happen often from these smaller vessels, so they're called a small vessel stroke. Remember I said lipoproteins can build up in these little arteries and cause strokes. And we have these little arteries they come off those big ones that I mentioned. So they come off, the MCA here, for example, we have small arteries that are feeding these deep structures in the brain. So you can see lots of different symptoms with these small vessel strokes. Some more common ones are when we see motor loss is going to be on one side of the body again, but it's going to be equal. You're not going to have the more face and arm than leg. You're going to have equal face, arm, and leg weakness or sensory loss. And the patient is going to be fully awake and conversational with you. So with some of those other strokes, they start to, get a little bit altered, but these strokes that are the small vessels, they're going to be awake and talking to you. All right, getting into hemorrhagic strokes. Remember, hemorrhagic strokes, there's lots of different brain bleeds that happen inside the brain, but strokes are just the subarachnoid hemorrhage and the intracerebral hemorrhage not due to trauma. So symptoms of a hemorrhagic stroke can be all of a sudden they have a headache, especially with that subarachnoid hemorrhage. A lot of patients complain of the worst headache of their life. Nausea, vomiting, and this is where we're going to see altered mental status. They might be real lucid right away and they're talking to you just fine. And then you get them into the rig and they start to go down. So these are the patients that could go down quickly and then you need to intubate them. Because remember that closed box, that blood is taking up space in that brain and it's causing high intracranial pressures that then begin to cause the brain to herniate and those patients to go down quickly. Other signs of a subarachnoid hemorrhage can be intolerant to light, so they are complaining that the lights are really bothering them, or neck stiffness. And then intracerebral hemorrhages, besides what I mentioned, they can look just like an ischemic stroke, because that intracerebral hemorrhage is in a certain area in the brain. So it's in a localized area of the brain. So it's going to cause symptoms like an ischemic stroke. And so that is one of the main reasons why we need to get that CAT scan before we're giving thrombolytics to any of these patients, to make sure that they don't have any hemorrhage in their brain or any reason why we would hurt them even further. These are just other examples of CT scans of that subarachnoid hemorrhage. This is the better one than that first one I showed you. This is a pretty big subarachnoid hemorrhage. So that's that blood around that brain. And then a little bit smaller of an intracerebral hemorrhage, but this is in that small arteries off of that middle cerebral artery that I showed you. That's exactly where that is. And that's the most common area for an intracerebral hemorrhage due to high blood pressure. All right, what is it when it's not a stroke, or what can mimic a stroke? What can look just like a stroke based on the patient's clinical picture? So hypoglycemia, even hyperglycemia can look just like a stroke sometimes. Doesn't mean that we might not treat that patient, but we'll correct the blood sugar first and then see if the patient still has symptoms. And then if they do, then we would treat them for stroke. Seizures, so after a seizure, patients can have something called Todd's paralysis, which looks just like a stroke. Migraines, people that have migraines can mimic a stroke. Tumors, obviously that's causing pressure and damage to a certain area of the brain, so can look like a stroke. Most of the time, patients complain of more gradual symptoms that are with a tumor rather than sudden onset of symptoms. Same thing with an abscess. And then a subdural hematoma can also look like a stroke. Obviously, these last three we're going to see on a CT scan, and so we're not going to treat those patients. We always say we would rather treat a mimic than miss a stroke. So sometimes we do treat patients that go on to actually not have a stroke, but we really wouldn't want to miss a stroke. And so if there is a possibility that they are having a stroke, then we will go ahead and treat them. All right, speaking of treatment. All right, for hemorrhagic strokes, well, really depends on what type of stroke they're having. So is it the subarachnoid hemorrhage or the intracerebral hemorrhage? For subarachnoid hemorrhages, when they come in, what we can do, if it's due to an aneurysm, we can go in and treat that aneurysm. So what we want to do is make sure that we take care of that so that it can't rupture again, so that that balloon is not getting blood flow anymore. And we can do that by either coiling or clipping. So coiling, we go up into interventional radiology, and they stick a catheter through the groin that goes all the way up into the brain, and they use fancy x-rays and to look at all those arteries and find the aneurysm. So the aneurysm's right here. And what they do is they pack that aneurysm full of tiny little titanium coils so that it clots off and can no longer get blood flow. So you can see here all these little squiggles there, and that's an aneurysm that's packed full of coils. So for clipping, what they do is they go into the operating room and they do a craniotomy, and then they find the aneurysm, and then they place a clip, a titanium clip right at the base of that aneurysm so that it can no longer get blood flow. So you see this aneurysm obviously is more of a balloon, it's getting blood flow, and then it deflates once that blood flow is stopped. For an intracerebral hemorrhage, again, we can go into the OR and try to get out as much clot with suction as we can. And when I say we, I do not mean me. I'm doing none of that. For either one, we can do EVD placement, so external ventricular drain, and I'll show you what that looks like in a minute. And then sometimes we just do medical management, especially if it's a small intracerebral hemorrhage, where the first things we want to do are blood pressure management. So a lot of times these patients as well will come in with really high blood pressures because the body's trying to get blood flow to the brain because it can sense that there's not enough blood flow up there. And so we do want to bring that blood pressure down because we don't want to cause further hemorrhage into the brain. So a lot of times we're going to bring that blood pressure down to about 140 systolically, and then we're going to reverse any anticoagulation that those patients are on. Here's an example kind of what the EVD looks like. So what we do is drill a hole through that dura and then put a catheter into the brain and then have it sit in the ventricle. And what that does is remember, it's a closed box, so it's going to help get rid of something when the pressures in the brain get too high. So that catheter then hooks up to this drainage system, and kind of based on where we place it, when the brain pressure gets to that level, so when those intracranial pressures get to that level, cerebral spinal fluid will then spill out to save room to decrease that pressure, so the pressure is not getting too high in the brain. You can see with this patient, cerebral spinal fluid is normally like a really pale yellow, but patient has had a subarachnoid hemorrhage, and so you can see there's some blood mixed with that cerebral spinal fluid. And then with these, we can also measure that intracranial pressure whenever we need to. All right, talk about ischemic stroke. So treatment for ischemic stroke is going to be thrombolytics, as you guys know. We have 2 different types of thrombolytics out there that we now have both approved by the FDA. It took a while for tenecteplase to get approved, but it's finally been approved. So you can treat either stroke with either one. UC Health has moved to tenecteplase for treating all of our strokes. In studies, they both performed equally well. There's a couple situations where tenecteplase probably outperformed alteplase, and then nationally, tenecteplase has a lower hemorrhage rate, symptomatic hemorrhage rate after giving it. It's about 3%. The studies with alteplase, they used to say 6%, but I really do think that alteplase has gotten to more than that 3% as well. But the thing with tenecteplase is that it's much easier to give. So there's much less room for error. So alteplase, you give 10% of the dose IV push over 1 minute, and then you have to hang the bottle as an infusion over 60 minutes, and then you give a bag of normal saline so that you make sure that you get everything in that tubing. With tenecteplase, all you do is an IV push over 5 seconds. So really a much easier way to give a medication much quicker for patients. So treatment options for either medication and then risks are the same. So with the thrombolytics, they can only be given within 4.5 hours of that patient's last known well, right? So I'll mention wake up strokes in a minute, but this is in general, we can give it within 4.5 hours. So last known well is that time that somebody saw that patient completely normal. So that could be before bed, and then they woke up with symptoms. That could be the time that patient, daughter left her mom and then went to the store, and then came back, and then the mom had symptoms and wasn't able to tell her when that happened. That time the daughter left and saw her completely normal, that is what the last known normal is. So that's the time we really want to know. With these medications, as time progresses, the benefit decreases and the risk of hemorrhage increases. So we're constantly trying to give this safely, but quicker. We're trying to give it quickly. We want our door to needle to be in less than 30 minutes now for a lot of our patients. So the first things we're going to do, we're going to get a head CT, right, to make sure that there's nothing that would prevent us from giving this medication, no hemorrhage, no abscesses, things like that. And then we want to rule out any exclusions. So exclusions really are any reasons why this patient might hemorrhage somewhere else. Have they had a recent trauma, head trauma, or body trauma? Have they had a recent large stroke? Are they on any blood thinners? Things like that are what we need to know about. And the only lab we need before we give thrombolytic is a glucose. to look for that hypo or hyperglycemia, unless we suspect the patient, you know, has low platelets or something for another reason. Side effects are obviously bleeding, and then a patient can develop angioedema, about 1% of the patients, which is like swelling of the tongue or the lips or the throat. So when you're reporting off to us, important things we want to know is that last known well time, right? Like I mentioned, that's extremely important when we're giving these medications, and if we can give the medications. The other thing is blood glucose, right? The only lab we need. If you can get our medications for the patient, but most importantly, medications, we want to know if they're on anticoagulants. Are they on a DOAG? Are they on warfarin? And then what does the neuro exam look like, right? How do we think that they're having a stroke? Can we localize this to a certain area of the brain? What do we need to focus on first? So really explain that neuro exam and what the deficits are for the patient. And challenge yourself on that neuro exam. I'll go through some different scales in a minute, but don't just do the Cincinnati. Look a little bit deeper into what's going on with that patient. And then a family phone number is huge, 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 especially if that patient can't talk, so they're aphasic or super altered. We really want to talk to the family before we give any of these medications. So if you can provide that number, that's super helpful. So there's lots of stroke scales out there. There's lots of scales that look for large vessel occlusions. And so there's not one that's been proven to be better than the other. And so find one that you like, that works for you, and challenge yourself to do a little bit better of a neuro exam. So that Cincinnati is really just looking at the front of the brain, but look at the back of the brain. Use an exam that can, you know, really look at all the symptoms of a stroke, in addition to whatever your protocol is. So Cincinnati, the MEND is one that I kind of like. It was developed by the University of Miami. It has the Cincinnati in it. That's kind of these highlighted areas. But then it gets a little bit deeper into examining the patient. So it looks at the visual fields, right? Remember I said that's the posterior cerebral artery that you're looking at. So a stroke in the back of the brain. So really what the eye is broken up into 4 different quadrants. Okay, so each eye has 4 different quadrants or visual fields. So what you want to do is you want to test each visual field. So you kind of get in the periphery of the patient, and then you can either ask them to tell you when your fingers are wiggling, or you can use numbers and have them ask you to tell you the numbers. And then you want to test each of the patient's visual fields in both eyes, one at a time. And then you can see if there's a little bit of a quadrant in both eyes on the same side that is missing. And then another thing that's going to test, remember that cerebellum, that back of the brain, is coordination. So doing finger to nose. So touch my nose, touch your finger, touch my nose, touch my finger. And you do that in both eyes or both arms. And then you do it in your legs. You have them rub their heel up and down their shin. And really you're just looking at if they miss. Okay. So are they missing when they touch your finger? Are they missing the finger? Are they having a really hard time? You want to make sure they're extending their elbow straight, but are they having a hard time getting to your nose, or do they miss their nose getting to your finger, or do they miss their nose? And then with the heel, when they're rubbing their heel down their leg, you want to just see if they're falling off. And sometimes you can even see it when they're bringing their heel to their knee to slide it down. You can just see that they're a little bit discoordinated, or they're having a hard time getting there. So just challenge yourself is what I'm saying. All right, I'm going to go through a patient case. So we have a 75-year-old male, has a history of hypertension, boarded a flight at 11:30 in his usual state of health. On the plane, his wife noticed he was not moving his right side and was unable to talk. The flight was diverted to DIA. The patient was brought in as a stroke alert. Blood glucose was 97. So wife saw him last normal at 12:15. He arrived to our ED at 2:05. The patient was found in AFib, per EMS told us that, found it on their strip, super helpful. Only medication they're taking is for hypertension, The NIH on arrival was 12. So the NIH score goes from 0 to 42, 0 being nothing, there are no symptoms, 42 being completely comatose. And most notably, the patient had aphasia and that weakness that she described. So if we're thinking about this patient, we're trying to figure out, is this a stroke? So does this localize to a certain area in the brain? So we have right-sided symptoms with the inability to speak, right? So what are we thinking for this patient? We're probably thinking a left-sided stroke, right? So the left side of the brain works the right side of the body, and the left side of the brain for most people has that ability to speak, right? And so we're thinking, yeah, okay, this could probably localize to a certain area of the brain. He could be having a stroke. So we get into CT. CT head here is negative for any hemorrhage. And then we always do a CTA with all our patients. The CTA, we give contrast, and it lights up that circle of Willis that I was talking about and looks for any large vessel occlusions. Because with symptoms like this, we're thinking of MCA, so we're like, maybe this could be a large vessel occlusion. Patient didn't have any known surgeries, no recent trauma, so no real exclusions that we know of. So is this patient a candidate for thrombolytic? So we're thinking about, blood glucose, we're thinking about last known well, is it within that 4.5 hours? Do we have a negative head CT and no exclusions for thrombolytic? And the answer here, right, is yes. Heck yeah, so we gave thrombolytic at 2:30, and then this patient spent about 5 days in the hospital, and then went home with an NIH stroke scale of 0 and no needs. So went from an NIH stroke scale of 12 to an NIH stroke scale of 0. So amazing. I love when that happens. And then this is the MRI, the different slices of the MRI. Remember the strokes, ischemic strokes are going to come up white on MRI. So these are a bunch of different little tiny strokes throughout the patient's brain. And the reason why, or the etiology we thought for this patient, was to be cardioembolic or coming from the heart because of that AFib. So I mentioned wake-up strokes. So about 20% of strokes are discovered when a patient wakes up. They went to bed normal the night before, and then they wake up with stroke-like symptoms. And so the highest risk of stroke is close to that time that the patient is awakening. And that is because in the morning, we have an increase in our blood pressure, an increase in platelet aggregation, and prothrombotic factors. And so there was a study done in 2018 that looked at strokes and aged a stroke or timed a stroke, figure out when that stroke happened based on different slices in an MRI or different images in an MRI series. And so we can use the MRI to treat patients. So what we're looking for, we do look at 2 different slices or 2 different types of images in an MRI, and we're comparing them, and what we want is a mismatch. So this DWI is going to show a stroke really fast. So we see the white of the stroke here, and then on the flare is what we don't want to see any stroke. We don't want a matched area. And so when we see this, we think that the stroke happened within about 4.5 hours. So they're within that window for us to give them thrombolytic. And so when a patient has a matched area, so like in these images, you can see there's white here and there's white here. So this is matched. And this means the stroke is probably over that 4.5 hour area time frame. And so we cannot give those patients stroke. So when a patient comes in with a last known well the night before, and they come in to the hospital within 4.5 hours of waking up, we rush those patients down to MRI and see if we can give those patients thrombolytic. It doesn't happen very often, but it's another small portion of patients that we can try and help. So another patient case, this patient was brought in by her husband after being found down at her bedside with stroke-like symptoms, had a blood glucose of 187. Last known well was 8 o'clock the night before. And then the patient arrived to the ED at 6:35 in the morning, so about 30 minutes after the patient woke up. NIH stroke scale was 10. The patient had word finding difficulties and left lower extremity weakness. did a head CT, which you can see over here. There was no hemorrhage, and the patient had no recent surgeries, no trauma. So she was just found down at the bedside. She had no trauma, and she wasn't taking any blood thinners. So what do you think? After what I just told you, is this patient a candidate for thrombolytic? Yeah, you guys are right. So not in that traditional sense, right? Not in the 4.5 hour window, but is this a wake-up stroke, right? So her last known well was the night before. She was completely normal. She woke up with stroke-like symptoms and came into the hospital within 4.5 hours of waking up. And so we could take this patient down for emergent MRI. And then we did the MRI, we compare the DWI, which is here. You can see the white, so she is having a stroke. And then there's nothing here, so it's not, we have that mismatch that we're looking for. At that time, we were given TPA for these patients. Now we're doing T&K. So TPA was given to this patient. And the patient was discharged home 2 days later with large improvements. So the NIH of 2, so went from 10 to 2. And one of our doctors had this patient write while she was when she first came in, while she was having her stroke. And then before she left, she had her write the same exact sentence. So this is supposed to be, "Hi, have a good day." But she was obviously clearly not able to write that. And then after the thrombolytic, she was able to write. Okay, other ways that we can treat patients. I'm sure you guys have heard of thrombectomy. And then we can also drip a little of thrombolytic or TPA into those arteries in the brain to try and open them up. So since 2018, we can start going out to 24 hours from the last known well for these patients that have these large vessel occlusions. So any occlusion in that big circle of Willis. Again, as time progresses, chance of benefit decreases, risk of hemorrhage increases. So we really want to save neurons, treat these patients as quickly as possible. Not many exclusions for thrombectomy, but we want to rule out any exclusions. For these patients, we're getting CT, CTA. CTA lights up all those large vessel occlusion or large vessels, and so we can see if there's an occlusion there. And then sometimes we're getting a CT perfusion, which I'll show you guys in a minute. Side effects for thrombectomy can be bleeding or reperfusion injury into that area that the stroke happened. And a CT perfusion helps us look at the core or the tissue that's damaged already and is dead and infarcted and cannot be reversed. And then it looks at the penumbra or the tissue that's reversible. So the penumbra, both of these things are going to cause that patient's symptoms. So by looking at a patient and what they look like, their clinical symptoms, we can't tell how big that stroke is. But a CT kind of gives us a picture of the dead tissue versus the tissue that's at risk if we don't take that clot out, and the tissue that we're trying to save. So a lot of times we'll discuss this when we're talking about that CTA, core versus penumbra. For thrombectomy, we're going to go up into that interventional radiology suite. They're going to put a catheter in, usually into the patient's groin. And then they use what we call a biplane, or it's just a really fancy x-ray to get that catheter all the way up into the brain and to where that clot is sitting. And I'll show you kind of a animation of that. So they put a guide wire up through that clot. And then stick the catheter up the guide wire, pull the guide wire out, and then put, this is what's called a stent retriever. So that's going to help us get out the clot. Take the catheter out, the stent retriever sits there for a certain amount of time. And then once hopefully that whole clot has been adhered to that stent retriever, they go ahead and pull that clot out of the brain. So remember that those large vessel occlusions happen in that circle of Willis and those major arteries that I talked about. So we can't go after every clot in the brain just because those catheters are just not small enough to get further out into the brain than that circle of Willis. So another patient case, 77-year-old female, past medical history of hypertension, presented as a pre-hospital stroke alert. Blood glucose was 88, last known well was 7:30 in the morning. So she was seen at 7:30 as normal. She was putting out her flag with her neighbor. She went inside to take a nap at some point, and went to go get out of bed, and she was unable to get out of bed. So she has this system with her neighbor because she lives alone, that once her flag is out and she's not seen out and about, then the neighbor needs to come in and check on her if she hasn't taken down her flag. So she went to see her. The neighbors saw that she couldn't get out of bed, so she called 911. The patient arrived to the ED at 1:30 p.m. and the NIH stroke scale was 16. So she had left-sided weakness and she had neglect. So thinking about where those symptoms are, do we think the patient is having a stroke? Do those symptoms localize to a certain area of the brain? So remember, the right side of the brain works the left side of the body, right? And with right-sided strokes, what we're going to see is some neglect, right? Possibly. So could be a right MCA stroke. So yeah, let's take this patient for CT. So CT head right here is negative for hemorrhage. No big dark areas, so none of those areas that I've shown you, those hypodensities. The patient had no recent surgeries, no trauma. Patient was not on any blood thinners. Is the patient a candidate for thrombolytic? I'm seeing some no's. And you guys are correct. Great job. So we're outside of the window for thrombolytic, right? So we went ahead, we did a CTA, and what we found is that patient had a clot in that parotid artery as it's coming into the neck, and then it's extending into that right MCA area. So you can see here, this is what a CTA looks like. It's lighting up that circle of Willis that I showed you guys. And we can see what we're looking for is symmetry. So we're looking for the same on both sides. And what you can see is that right MCA is missing on this side, right? We don't see any vessel lit up on this side of the brain. And one thing I want to show you guys is sometimes we can see that vessel that's occluded just on a CT. So we call this a hyperdensity. So it's a whitened area instead of that hypodensity, a darkened area. And we can actually see that blood clot sitting there on that CTA. So again, what else can we do for this patient? What other treatments options do we have for this patient? Yeah, we can go in for thrombectomy. Yeah, excellent job. Yeah, absolutely. So she's within that 24 hours, right? And then for this patient, we did a CT perfusion. So remember, that's looking at core infarct, so dead tissue versus tissue we want to save. So tissue that's at risk, but it hasn't died yet. So these are all these different slices in the brain like this. And the purple area is depicting area that's already dead. And then this green area is kind of the same slice. And this is the area that's at risk. So you can see, like, for instance, in this one, there's all this green area, but there's just a tiny bit of purple area. So that's a pretty decent amount. And the same thing here, right? There's green area that's at risk, but there's not a purple. So this tissue isn't dead yet. And so we want to try to save that. And so, yeah, absolutely. Great candidate for thrombectomy. So went to IR for this patient. We did a thrombectomy with a TK3, which means we get all the clot out. Also, this patient needed a stent placed in her internal carotid artery because she had a bunch of plaque there that was kind of clogging up that artery. She left with an NIH of stroke scale of 0. She did need some assistance with self-care, and so she went to inpatient rehab for a little bit after our stay with us. And then for this patient, we thought the reason or the etiology was, since we saw all that plaque in her carotid, was most likely what we call large artery athero. So plaque went up into the brain, or a clot formed and went up into the brain. And then this is what her MRI looked like. So all these white areas are strokes. All right, another patient case. There was a 75-year-old female sitting at lunch with her family in Akron, Colorado. At 12:30, she had sudden onset of word finding difficulty. Family noticed she was saying words that just made no sense to them. So they called 911. Patient was a former smoker. She's not taking any medications. So what do you guys think? Stroke? No stroke? Think about, can we localize that to an area of the brain? Should we call a stroke alert? Yeah, right? We are thinking about that aphasia, right? Yeah. We're thinking about, she's just making no sense, right? And so this could definitely be a stroke. And so this patient was transported via life flight as a stroke alert to us. The stroke alert was called prior to the hospital at 2:07. She arrived about 20 minutes-ish later. When she arrived, her NIH was 1 for just some facial droops. So this nasolabial fold was flattened a little bit. So a tiny little bit facial droop. So she had resolved some of what was going on. Blood glucose was 86. We did a head CT. Head CT was negative. So no blood or anything that could contraindicate her from or exclude her from thrombolytics, and no hypodensities. So what do you guys think? Should we administer thrombolytic for this patient? So she's within the window, right? So we're about 2 hours into her stroke, or maybe stroke, right? We don't know for sure until she has an MRI. But pretty minimal symptoms, and thrombolytics not without risk, right, you guys? So what we do is we talk with the patient. And yes, her speech is normal. So we talk to the patient, we say, is this disabling to you? So when it's not that we won't treat patients with low NIH stroke scales. What we want to do is we want to talk about whether that is disabling. Can that, if you were to remain this way, could you perform all of your normal ADLs? So we talked to the patient. She didn't feel like it was disabling. So at that point, we did not give T&K. But then while she was sitting in the ED at 3:34, the patient worsened again. So she had some expressive aphasia. Her NIH stroke scale went up to 3. She was just not really able to get her words out. We did a repeat CTA, make sure, nothing had changed. She hadn't developed a large vessel occlusion. Everything there was negative. So, I said, should we administer T&K? But then I gave you the answer. So we did administer T&K then. So we were still within the window for that patient. We were still within the 4.5-hour window. And now these symptoms are disabling to that patient, right? And so we went ahead and gave the T&K, and about an hour post T&K, her symptoms had again resolved. Thankfully, her MRI had shown no stroke. And sometimes when we really feel like the clinical symptoms met an area in the brain, but the MRI shows no stroke, we call that a thrombolytic aborted stroke. So we treated that patient quick enough that the brain actually had no damage. And that patient was discharged home the following day with plans to follow up in the clinic. So at that point, we had no reason for her stroke or etiology at the time of discharge. All right, okay, 40-year-old woman arrived to the ED. The EMS is a stroke alert at 2:55. Patient has a history of migraine headaches. She presented with left-sided weakness, a right gaze preference. She was staying in a motel and was supposed to check out that day, but when she didn't, the staff called for a wellness check. So when EMS arrived, they found her in the corner of the room. Patient was able to verbalize that she was not taking any medications. So what do we think? Is this patient a thrombolytic candidate? So we think she's having a stroke, so her symptoms are left-sided weakness. She's got a right gaze preference, right? Also, yeah, not enough info. Good. Yeah, good. Yeah, we don't have enough info. Not quite yet. And so just remember that left side of weakness, right side of the brain, right? Patients are going to look towards their stroke, right? Excellent. Good job, you guys. Yeah. What other information do we need? You guys are throwing it in there already. Great job. Yeah. So her last known well, we weren't quite sure because she was found, right, down. Blood glucose was 123. You know, we already talked about no recent surgeries, no trauma that we could see. Her NIH was 11, pretty high, right? And then we did a non-con head CT, right? So we always got to do that before we're giving any thrombolytics. Stop. So she had a hemorrhagic stroke, right? So you can see that hemorrhage right here in the right side of her brain. So remember those tricky intracerebral hemorrhages can look just like an ischemic stroke. So she was monitored in the ICU for 7 days, and then she got discharged to inpatient rehab. We thought the reason for her ICH was due to transient hypertension in the setting of stimulant drug use. So she was positive for amphetamines and THC. But we also will get an MRI later to make sure that there's no, once that blood kind of gets reabsorbed into the brain, just make sure there's no underlying lesion that we're missing. At discharge, she had some slight left upper extremity weakness, was able to ambulate independently, just needed some assistance with ADLs and having some memory lapses. She discharged home from therapy about 5 days later. So got some therapy and then went home with outpatient therapy. Next case here, a 71-year-old male is driving his car around 4:20 p.m. He developed sudden onset of double vision, slurred speech, clumsiness, had a history of hypertension, pre-diabetic, and an aortic valve replacement, but was not on anticoagulation. Blood glucose was 170, no recent surgeries, no trauma. NIH was 6. What do you guys think? Stroke? Do we give thrombolytics? Need some more info? Yeah, possibly. Blood glucose was 170. Do non-con head CT. Non-con head CT looked good. There was no blood, no big hypodensities. So for this patient, I don't think I gave the time the patient got there, but he was within the window, sorry. Within the window for thrombolytic. And so we went ahead and can give him thrombolytic. And then when we did a CTA, he actually had a clot at the top of his basilar and into that posterior cerebral artery. So that first part, we call it the P1, that first part of that posterior cerebral artery. So remember, those posterior symptoms can look a little bit different than the front of the brain, right? So went ahead and take this patient for thrombectomy, got a TK2B, which is almost the whole clot. This patient we thought was his stroke came from his heart because he wasn't on that anticoagulation that he needed to be on for his aortic valve replacement. He did have resolutions of most of his symptoms, just had a little bit of gait instability and was discharged from the hospital 2 days later with outpatient therapy. Don't have an MRI on this guy due to he had some sternotomy wires still in place. And so we couldn't do MRI with that metal in his body. All right, this patient, 45-year-old female, history of asthma, normal around 9 p.m., found shortly after by a family member with slurred speech, right-sided weakness. EMS was called. Stroke alert was called prior to the hospital arrival. She arrived at 9:40. NIH at that time was 24, so decent. She had dysarthria, left gaze preference, right-sided weakness and sensory loss, and aphasia. CT was negative. She wasn't on any medications, had no surgeries and no recent trauma. So what do you think? Does this patient have a stroke? Should we give this patient thrombolytic? You know, where do we think this stroke is happening? Do we think it's stroke? Yeah. Need a blood glucose, right? Yeah. Let's say their blood glucose is normal. Say it's 120. So we have that right-sided weakness. We have that right-sided sensory loss and that left gaze preference, right? So she's looking towards the left. We're probably having a left-sided stroke, having that aphasia too, right? We're thinking, yeah, it localizes to an area of the brain. It localizes to an MCA, so she could very well have a large vessel occlusion as well. And yeah, she's within the window for thrombolytics, and had no contraindications. So we did the CT, was negative, we gave thrombolytics, we do the CTA, and we see that she has an occlusion here in that middle cerebral artery. So you can see there's no contrast getting through to this artery. It's not the same as this side. So she had a left MCA, it was the carotid into the middle cerebral artery, clot sitting there. We did a CT perfusion on her. Her CT perfusions, she's, you know, not quite as a mismatch, or there's large stroke happening, large core infarct, but we still wanted to take this patient. She had severe deficits and she was within that 24-hour window. So this is what it looks like when we x-ray up in interventional radiology. So you can see the carotid kind of coming up here, and there should be a lot more blood vessels after this carotid here. So there should be blood vessels sitting there when the contrast goes in. So they go ahead, they take pictures as they're putting up the catheters. So remember, you saw in that cartoon, you saw that catheter that went up, and then the stent retriever goes into that vessel. So you can see all these little markings on the stent retriever. So it's sitting in that middle cerebral artery area. And this is what it looks like in the room when they're doing it. So they're, you know, the catheters are going into the patient here, and then they're taking pictures and watching as their catheters are going up into the brain. Pretty amazing that they can do that. And then they went ahead and pulled out the clot, and now this is what the picture looks like. So a lot more arteries now, thankfully, for that patient. And that's just the example of those two. And then this patient went home about a week later with an NIH stroke scale of 6. So this is her stroke here, pretty decent sized stroke, but went from a 24 to a 6, and was able to go home. Next patient, 40-year-old female, history of hypertension, recently diagnosed, arrived via EMS, having the worst headache of her life. Otherwise, her exam was non-focal, so she had no other deficits. Since she reported that worst headache of her life, we were concerned for a hemorrhagic stroke. Blood pressure on arrival, obviously elevated, right? And so we went ahead and did a CT. And you can see here, see that blood that is filling that subarachnoid space. So see that whiteness here? So this patient was having a subarachnoid hemorrhage. Declined rapidly. Remember, patients can do that with those hemorrhages. So she needed to be intubated in the emergency department and needed that external ventricular drain placed. When we did a CTA, we do CTAs for these patients as well to see if we can light up again that circle of Willis and figure out where that aneurysm is. So she had a aneurysm in the anterior communicating artery. So remember, that's connecting that MCA with the anterior cerebral artery. So right up here, she had her aneurysm. And then we went up and we coiled it. So placed all those little tiny coils in that aneurysm so it couldn't get blood anymore, and couldn't re-rupture. And she went home 21 days later with no neurological deficits. So for subarachnoid hemorrhages, we monitor them in the ICU for about 21 days for something called vasospasm. All right, next patient. This patient At 5:35 p.m., Bennett Fire was dispatched to the home of a 63-year-old male with complaints that he was having a stroke. On arrival, he was alert and oriented, and his wife noticed that his speech was off at about 5:25 p.m. EMS noticed the right-sided facial droop and slurred speech. Patient had stopped taking blood thinners about a week ago. Blood glucose was 186, had normal gait on the transport to the stretcher. They called Cat 1 for a rendezvous. Blood pressure was 129/99, heart rate of 101, respirators of 20, and SATs of 95. So care was handed off to the MSTU at 6:10 p.m. NIH was 2. Patient had a history of cardiac stents. Blood pressure was a little more elevated once she was on MSTU. And then we did a non-con head CT here. And again, I gave you the answer, dang it. So for this patient, we had to bring down the blood pressure a little bit before we can give T&K. So for T&K, we have to have the blood pressure less than 185/110. So they gave a little bit of labetalol, rechecked that blood pressure, and then went ahead and administered T&K to this patient at 18:30, and then brought her into the hospital. Okay. And then this patient had strokes. You can see different slices here, and that's called the left lateral precentral gyrus. So in one of the motor strips there. Etiology possibly due to heart failure and left ventricle hypokinesis. And so during that workup, they were trying to figure out why this patient was having his stroke, but on hospital day 3, he requested a leave. Some might say made the decision to leave AMA. So further workout to be completed as an outpatient, but was sent home on aspirin and a statin, which is pretty much almost every stroke patient. For how long? Good question. So the question is, for how long do we need to make sure that blood pressure is low? So about 5 minutes, we wait until that blood pressure remains less than 185/110, and then we give the thrombolytic. And then as we're monitoring that patient, we still want to make sure that that blood pressure stays in that range throughout that next 24 hours. Good question. Okay, I think this is my last one, and I have 1 minute. So 72-year-old female has history of hypertension, hypothyroidism, was with her son at 10. She had sudden onset of inability to speak. EMS was called. The patient was brought in as a stroke alert. Arrived at 10:51. What do you guys think? Stroke, no stroke? Where could she be having her stroke? And is she a thrombolytic candidate? So we need more information, right? Yeah. So last known well, yep. We got that, right? So she's within that window. Blood glucose was 106. She didn't have any trauma, no recent surgeries. We got an NIH stroke scale of 9, and then our CT was negative. And patient with sudden inability to speak, right? So we're thinking possibly the left side of our brain, right? Because that's where our language centers are. And so could be on the left side of the brain. We did that CT, negative, and then we did a CTA. And lo and behold, that patient has an occlusion in her left middle cerebral artery. And so we gave T&K and then went to IR for thrombectomy. And this is the patient's CT perfusion. So this one definitely has more of a mismatch where we have the core here and then the big tissue at risk. And we did TK3 on her, so we got that full clot out, and she was being able to discharge a couple days later, no disabilities, and a tiny, ever so tiny stroke. So we got to her pretty quickly. So helpful things, like I mentioned, what are the symptoms you guys are finding? When is that last known well? Are they on any blood thinners? And then that family contact is super important to help us figure out that patient's history and consent that patient if they're unable to. So I appreciate you guys listening to me. If there's any questions, I'm happy to stay a little bit longer and answer some questions if anybody has anything they want to talk about. I'll hang out. but thank you.
Thank you, Carrie.
Yeah.